Good evening, everyone. Welcome to Master Classes in Critical Care Medicine from Yashoda Hospitals in association with the ISCCM Hyderabad chapter. Today's case for discussion is weaning failure. Topic will be presented by DRNB students from Apollo Hospitals, Mumbai. Dr. Ganesh and Dr. Anjana will be presenting the case. To take the case, we have senior examiners, Dr. Anup Kumar. He is the Chief of Critical Care Medicine from Baby Memorial Hospital, Calicut, Kerala. And another examiner is Dr. Pradeep Bhattacharya, Senior Consultant from Ranchi. Dr. Ganesh and Anjana, you can start the case.
We'll wait for the Dr. Pradeep to join, no?
No, Dr. Anup, he said you can start, he's joining.
Okay, fine. Carry on.
Anjana, you can start presenting the case. As Ganesh, you start presenting the case.
Okay. Good evening. My screen visible?
Yes, it's visible. You can proceed.
Thank you. So, this is a 47-year-old female patient, resident of Mauritius, who is a housewife presented with chief complaint of breathlessness since 1 year, which worsened over 15 days from MMRC grade 1 to grade 3. No history of fever, cough, chest pain, abdominal pain, swelling of legs, decreased urine output or syncope. Past history, she was admitted in a hospital in Mauritius where she was initially diagnosed with right massive pleural effusion with underlying collapse. HRCT test done on 29th of October showed an enhancing lesion of size 84 by 81 millimeter in right hemithorax and left subpleural nodules of size 11.6 by 14 millimeter. Mini thoracostomy and thoracoscopy was done on 1st of November over there, which showed large multicystic lesion occupying almost whole right pleural cavity. CD34 vimentin was positive, Ki67 was positive in 3 to 5% of cells. Histopathology was sent, which was suggestive of mesenchymal tumor. She was shifted to our hospital on 4 liters of oxygen after right ICD insertion, right side ICD insertion.
So she was, can I interrupt?
Yes.
So she was operated from an outside hospital in Mauritius and shifted here, or was operated?
No, she was, the ICD was inserted and she was shifted. She was not operated over
The thoracoscopy was done from outside hospital.
there. Yes, thoracoscopy was done, mini thoracostomy and thoracoscopy was done. But the mass, there was a mass which was still there.
Okay, fine. Can you just describe about the markers and their significance? No, you don't know. CD34 vimentin was positive, Ki67 was positive in 3 to 5% of cells.
Yes, sir.
So what does that indicate? Okay, we'll discuss. You proceed.
Yes. So histopathology was suggestive of mesenchymal tumor. She was shifted to our hospital on 4 liters of oxygen after insertion of ICD in the right side. Family history, no significant history. Drug history, not on any regular medications. Personal history, not a known smoker, non-alcoholic, consumed mixed diet, bowel and bladder habits are regular. On general examination, she was obese, well-nourished, no pharyngitis, plugging, cyanosis, or lymphadenopathy. Vitals were like pulse rate 99 beats per minute, normal volume, regular in rhythm with all peripheral pulses felt. BP was 116 by 74 millimeter of mercury on right arm in supine position. Temperature was 97 degree Fahrenheit. Respiratory rate was 24 breaths per minute. Saturation was 98%. She was intubated in our ER. So if I on 40%, she was maintaining 98%. On PEEP of 6 and tidal volume of 360 and respiratory rate of 24 per minute. She was on examination of the respiratory system, where she was intubated and kept on ventilator of FiO to 40%. Chest movement was decreased on right side. Dull note was percussed over right infraclavicular, mammary, and infraaxillary area. Breath sound decreased in right infraclavicular, mammary, and infraaxillary area with crepitation present in infraaxillary area and lower interscapular area. On CVS examination, apex beat palpated at fifth intercostal space, mid-clavicular line. S1, S2 present, no murmurs or thrill present. Per abdomen, it was soft, non-tender, no organomegaly. All hernia orifices are normal. CNS-wise, she was under sedation, pupils bilaterally 2 mm, equally reacting to light. So, provisional diagnosis was right intrathoracic mass with underlying pleural effusion with collapse. On arrival to ER, she was drowsy. GCS was E2, B2, M4. She was intubated in ER and shifted to ICU. ABG before intubation showed pH of 7.035, PCO2 of 130.4, and PO2 of 87.9. Bicarbs of 34.1.
So
this was
okay, just next slide. After the next slide, you can stop.
So this was the X-ray on arrival to ER and ABG on in the ER.
So what is your inference at this point? What may be the reason for drowsiness, and what made us to intubate her?
So the ABG was suggestive of raised PCO2. PCO2 is 130.4. So hypercapnic pH of 7.035. So hypercapnic respiratory failure would be the hypercapnia would be the reason for her drowsiness.
And what other inference can you make? Is it a acute one or a chronic one?
So bicarbonate is 34.1. So it points more towards the chronicity of the events.
Okay. Okay, proceed. And the X-ray, what is it showing?
So the X-ray, on X-ray, the right side of the right thoracic cavity is showing opacification. So some space occupying some mass or pleural effusion.
Was there a CT available at that time after thorax?
Post intubation CT was done, sir.
Okay.
Baseline investigation was sent on arrival on 26th of November, which was fairly within normal limits. The successive investigations were also within normal limits. Thyroid profile was sent to TSH was 0.32. Other than that, cardiac markers, troponin was negative, tropi was 2 and NT-proBNP was 138. ProCal was 0.03 and C-reactive protein was 44.6. On day 1 of admission, she was hypotensive with the blood pressure of 84 by 50. Started on injection Piptas 4.5 gram 3 times a day. Empirically, after sending cultures and noradrenaline support. Invasive lines were secured. USG test was done, which was suggestive of ill-defined heterogeneous hyperechoic lesion in right lung with around 400 to 450 ml pleural fluid in the right pleural cavity with collapsed consolidation of underlying lung and 300 ml fluid in the left pleural cavity. On day 2 of the admission,
just go back. So the ICD was in situ.
Yes, sir. ICD was in situ.
Okay. Still the 300 ml fluid was left.
Yes, sir.
How will you make out with ultrasound that there is a 300 ml, exactly 300 ml of fluid is left in the pleural cavity?
Sir, we under the ultrasound we measure the distance from the diaphragm to the this thing, sir.
Diaphragm to the upper part of pleural.
Part of the probe, sir. So the distance that approximately gives us the volume of the fluid, sir.
So it is just approximate estimation only you can make out. You cannot,
Yes, sir.
especially with the lung mass and all, you may not be able to make an exact amount that 300 ml of fluid is left by looking at bedside ultrasound. I don't think that will be possible. You can get a
Right,
just rough estimation that how much fluid is remaining and what may be the reason why the fluid is left behind even after an ICD is in situ.
So there can be loculation, septate formation can be there. So
Yeah, very good. Other than that, it may be blood and the blood like might have the blocked the tube. That also may be the reason. Okay.
We invite Dr. Pradeep Kumar Bhattacharya, sir, who is the head of RIMS in Ranchi. Sir, we welcome you. He's a seasoned senior clinician in the critical care department, as also the president-elect. Sir, we welcome. It is our honor and privilege to have you here in this session, sir. So we have a case which Dr. Ganesh is presenting. He's a DRMB student. So Dr. Ganesh, you can just brief him so that both Dr. Pradeep and Dr. Anup can take the case forward.
Good evening, everybody.
So
You can just brief Dr.
Yes.
Ganesh.
So, yeah, so this was a 47-year-old international patient came to our hospital in hypercapnic respiratory failure. She was having a right-sided mass for which thoracoscopy was done and right-sided ICD was inserted in Mauritius and was shifted here for further management. On arrival, she was when she was shifted shifted on 4 liters of oxygen, but in ICU she was having a poor GCS, for which she was intubated and shifted to the ICU with on ventilator on FiO2 of 40%. This was her ABG, pH of respiratory acidosis, suggestion of respiratory acidosis.
Post-operative recovery was uneventful.
So actually, she was shifted for the operation over here, for removal of the mass. There was thoracoscopy only was done at the Mauritius.
Okay.
Yeah.
So he reached your hospital in after the surgery.
After ICD insertion and thoracoscopy.
Okay, ICD insertion and thoracoscopy. And while when he came to the hospitals, he was all right.
In ER, she was drowsy. Sir.
She was drowsy. Okay.
She was drowsy, GCS of E2, V2, M4.
Okay, the cause is quite obvious. Carbon dioxide is very high.
Yes, sir.
So now, then, after that?
USG done, which was suggestive of some fluid collection. CT chest and abdomen with contrast was done, which showed large enhancing solid cystic lesion with enhancing septate in right hemithorax extended into anterior mediastinum, causing near complete collapse of the right lung with mild right pleural effusion, suggestive of extrapulmonary origin. Areas of ground glass opacity, attenuation in upper lobe of left lung, and few atelectatic changes with patchy areas of consolidation and inferior segment of left lung was seen. So this was her image of the CT scan.
So basically, this patient is a one lung patient, isn't it?
Right, sir. Yes.
And one lung is completely gone.
Atelectatic changes. Yes.
So what is the physiological changes which happens in patients who are having only one lung?
There is compensatory mechanism which the contralateral lung expands in size.
Expands in size. Why do you think like that? Because is there's the rib cage will allow the lungs to go beyond its limit.
No, sir, not beyond its limit, but there will be hyperinflation of the opposite lung, sir.
Indirectly, I want to ask that how he compensates, the patient compensates for the whole demand of the body. Okay. Initially, there was two lung which was maintaining the supply and demand ratio of the body. Now there is only one lung.
Right, sir.
Now, how it is going to take over? What are the functional changes which will happen in the lung? Have you read it?
No, sir.
No. So you are practicing anesthesia or medicine?
So, actually, done my anesthesia in 2006.
Okay. Have you taken any case of pneumonectomy previously?
During my residency, yes, sir.
You have taken cases of pneumonectomy.
Yes, sir.
So what happens at that time, might have read what happens to the other lung after one lung is removed in surgery.
So,
There has to be an increase in what? Both? What are the two main functions of the lung?
ventilation and perfusion.
Ventilation and perfusion. So what do you expect from the other lung?
So,
What
do you
change?
expect?
What changes in these parameters you expect?
so the one ventilation is hampered, but perfusion will be there. So,
Yes. Keep it up. Hmm.
So when ventilation is will be present and perfusion ventilation will be absent and perfusion will be present, sir, because the lung parenchyma is not functional.
No. Ventilation will be absent means do we extubate this patient after the surgery or not?
No, sir.
After the surgery, we keep the patient on tube for lifelong.
No, we do extubate, sir.
We do extubate the patients.
Yes, sir.
So how do you feel that? How they compensate for the other lung? What is the most important thing which is required to maintain the adequate oxygenation and perfusion? Do you expect that the blood supply inside the lungs should increase a little bit to compensate for that?
On the contralateral side, yes, sir. But on the
Do you think that the functional residual capacity of the opposite side should increase a little bit?
yes, the opposite side functional residual capacity will increase, sir.
And do you think that oxygenation from the opposite side should increase a little bit?
Yes, sir, to compensate the contralateral.
So overall, what is going to happen? How these things are going to happen?
Dr. Anjana, you can also answer. There is one more presenter, sir, in this group.
Okay.
You are presenting.
Who is that? Dr. Archana.
Anjana.
Acha. So you can also answer if you have something in your mind, because this is important. If you manage cases of surgical cases, thoracotomy cases you might be managing in your ICU. I know that you are working in a very good setup, and that kind of cases are very common. So that is why, even if when you go for independent practice, you may get such kind of cases. So you have to know the physiological adjustments which the lungs do after such kind of, because this case which you are presenting will almost behave in a similar way once you try to extubate this patient. Isn't it?
Yes, yes, sir.
Okay, keep on going. We'll discuss about those points. So what happens after that?
So on day 3 of admission, there is persistent CO2 retention.
Okay.
2D echo done, which was it was normal. Patient was evaluated for causes like acetylcholine receptor antibody, anti-musk antibody, beta HCG, and alpha fetoprotein.
What was the need of doing these tests?
So there was a mass lesion, and we were suspecting some tumors. That's why it was sent.
Okay,
Yeah.
fine.
A CVTS reference for surgery was done. On day 4 of admission, noradrenaline tapered off. PCO2 was still high.
Mhm.
Day 5 of admission, right thoracotomy with sternotomy.
Can you, Ganesh, can you just go back? So that you have evaluated the causes and sent some tests, he asked no. So these acetylcholine
Yes,
receptor
yes.
antibodies and all you are sending to look for some tumors or something else?
My acetylcholine receptor for myasthenia gravis.
Okay, and what about other things?
Did you get any clinical finding of myasthenia gravis in this patient?
You know, why the myasthenia antibody was like sent? Was there any clinical features, or what are the usual clinical features you see in a like when you suspect a myasthenia gravis?
There was hypercapnia, respiratory, the muscle weakness is there. Diplopia is present.
Diplopia is the first sign for myasthenia gravis.
Is
Diplopia.
ptosis is the first sign.
Ptosis is the first sign.
Yeah.
So you cannot evaluate ptosis if the patient is on sedation, isn't it?
Yes, sir.
So what other things you will see?
Reflexes can be seen, sir.
Hmm? How do you differentiate the feature? Why you did this anti-musk antibody? What was the need of this testing? Do we do it for all cases who are supposed to be weaned from ventilator?
No, sir.
No. So any specific reason for getting beta HCG? Has it got any relevance with weaning?
No, sir. No, sir.
About AFP?
No, sir. No relevance with the.
So you will be appearing for the exam, I suppose.
Yes, sir.
So please try to avoid these things. Otherwise, you'll get leading questions.
Right, sir.
Okay.
Yes.
The things which are not relevant from our critical care point of view or from the point of ventilation, weaning, or whatever it is, these are unnecessary things and they will distract the examiner.
Right, sir.
Got it?
Yes, sir. Yes.
Okay. Now go ahead.
So on day 5 of admission, right thoracotomy with sternotomy with intrathoracic mass excision with right-sided ICD done. 4 liters of blood loss was there. Patient was in hemorrhagic shock when shifted to ICU. Received 3 packed blood cells and 4 FFP from OT. Transfused 2 blood cells in ICU and coagulation parameters and tech was sent, which was normal. Patient was hypotensive, requiring noradrenaline support.
What was the hemoglobin at this point of time?
So HB on day 5 was.
No, immediately after post-op, the previous slide.
You gave patient lost 4 liters of blood.
Yes, sir.
It is do you call it as a massive transfusion?
Yes, sir, it is a massive transfusion, sir.
It's a massive transfusion. So,
So
what are the consequences which can happen because of massive transfusion?
Massive transfusion can lead to various, there can be hypothermia, metabolic acidosis, hypocalcemia can be there, sir. There will be
what electrolyte imbalances other than
hyperkalemia will be present, sir. Hypocalcemia will be there.
So
What about lungs?
Sorry, sir.
What about lungs?
what changes in lungs you expect immediately?
Lungs, due to massive transfusion, there can be extra, like the patient may land up into acute lung injury or ARDS.
Other than that, okay. Other than that, any specific transfusion related issues?
Trali can be there, sir. Transfusion related acute lung injury or transfusion associated cardiac overload can be there, sir.
What is the probability of getting trali in a patient who has got malignancy and that too in the lungs? What is the possibility? What the literature says?
Exact value I don't know, sir, but there is high probability of going into trali, sir.
They are 4 times more vulnerable to get trali as compared to normal patients, isn't it?
Yes,
so they are highly vulnerable. So if they have lost 4 liters of blood as hemorrhagic in the form of during surgery, and the patient has developed hemorrhagic shock, and you have given 3 PRBC immediately, and then 4 FFP, and then again 2 PRBC, then what happened to? Did you investigate it immediately? What happened after that?
I didn't get you the questions.
No, what other investigations did you do, like after the transfusion? Usually, like after a massive transfusion, patient is
Yes,
coming back to your ICU. So,
Yes,
what are the
sir.
investigations you are asking, or whether this coagulation parameters and TEG is enough for you to manage such a after a massive coagulopathy, sorry, massive blood transfusion and a blood loss? What other parameters are required at this point?
Sir, electrolytes are required, sir. Hemoglobin, platelet
What
counts.
specific electrolyte you look at other than
Potassium.
The patient after a massive transfusion, you expect like a coagulopathy and an ongoing bleeding. So what are the along with the correcting coagulation parameters, what are the other prerequisites? Correction. You want to correct acidosis or you accept acidosis?
No, sir. We need to correct the acidosis.
Then what about calcium levels?
So the calcium levels due to the preservative, the calcium levels are decreased. So we need to correct the calcium levels also, sir.
No, to have a coagulation or to maintain the coagulation, you have to keep a calcium levels also. Usually how much?
We keep the calcium level at ionic calcium around 1 millimoles, sir.
Okay, and what is the other thing after a like such a massive transfusion surgery, lung surgery? What other parameter you have to monitor?
We need to monitor fibrinogens, D-dimers.
That anyway you have done the TEG and you have corrected that. Other than that,
Yes.
will you monitor the temperature?
Yes, sir. Hypothermia will be there. So we need to
hypothermia, hypocalcemia, and acidosis. So these are the crucial issues which we have to address, like when you receive a patient immediately from the OT.
Right, sir.
Okay.
This is a lethal triad.
Lethal triad of drugs. Yes, sir.
And what else will you monitor? There is already an ICD in situ. So any patient coming after thoracic surgery, you have to see like how much
drainage per hour.
Now you have started noradrenaline to the patient.
Yes, sir.
What about Crystalloid supplementation. How much crystalloid did you give?
So fluid resuscitation was continuous, sir. Fluid resuscitation was done with the under USG IVC monitoring, sir. So
What monitoring? How did you assess the volume status of the patient?
by monitoring the IVC state, IVC collapsibility.
Do you think IVC will be a true guide to the volume replacement in this patient who has got such a huge tumor in the thorax?
So thorax, the tumor has been was removed during these times.
No,
Even after removal, do you think that IVC is going to guide you properly?
or previously, like this patient, if you have done an echo with a like long-standing, like sir was explaining, one side lung is already gone. She's having a chronic type 2 respiratory failure. So what other finding would have been there in the echo?
There would have been change. Pulmonary hypertension can be there. There can be
Right ventricular dysfunction and pulmonary hypertension can be there. So, as sir asked, so whether IVC collapsibility index will be useful at that point with a high tricuspid jet?
No, sir. IVC collapsibility is not.
Then
So we can go for invasive hemodynamic monitoring like pulse pressure variation or stroke volume variation, sir.
What is the ideal hemodynamic tool at this point of time, as per your knowledge?
Pulse pressure variation will be ideal, sir.
Why?
Because
everything has got some one thing, then that is why you have to answer. You're going to become a consultant, isn't it?
right, sir.
Huh?
Yes, sir.
After passing this exam, you will become a consultant. So you have to tell why. If you are thinking of pulse pressure variation, why pulse pressure variation? Acha, any other thing? Why do you think that volume status assessment is important at this point of time?
Yes, sir. Volume status assessment is important, sir.
Why?
So so that we do not we do not overload the patient with the fluids, sir.
Now the patient has got a limited capacity. He has already lost his one lung.
Yes, sir.
He will be working with only one lung, and if you give if your balance gets disturbed, overhydration, excess fluid, lungs damage because of trolley, all these things are going to hamper your weaning process, isn't it?
Yes.
So your balancing the hemodynamics, patient already is in shock at this point of time is very, very important. So what you will do, or even you want to measure a pulse pressure variation, what hemodynamic intervention you will do to this patient?
The arterial line insertion.
So till now you have not put an arterial line, isn't it?
No, lines were secured, sir. Lines were secured.
Lines were secured. Okay, fine. Okay, now you go ahead further.
So on post-op day 1, patient was persistently hypotensive, requiring noradrenaline at 10 microgram per kg per minute. High ICD drain output was there. A change to negative
Now
pressure.
you tell me, this is another question which arises at this point of time. Why this patient was persistently hypotensive? Because why I am asking this question? Otherwise, before taking for surgery, his hemodynamics was normal.
Yes, she was hypotensive, sir, on admission also.
Now, what was the cause of hypotension? What was the cause of hypotension?
On admission, sir, because of maybe she was intubated, so medication given might cause a transient hypotension during that period, sir. But post-op, she was persistently hypotensive.
No, I'm asking about pre-operative period. You took this surgery as an emergency or you took this surgery as a routine surgery?
Sir, elective surgery.
You took it as an elective surgery, na?
Yes, sir.
Do we consider such kind of patients for elective surgery? If the patient is hypotensive, do you consider a shock patient for elective surgery?
No, sir.
So how did you took this patient for elective surgery?
Sir, she was optimized and then posted for the surgery. BP was stabilized and then posted. Sir.
So you said she was hypotensive at the time of surgery. She was in shock.
On day 1, sir. She was taken for surgery on day 5, sir.
No, on day 1. So that is what I'm asking. Before surgery, her hemodynamics were normal, na?
Yes, sir. Yes, sir. Yes, sir.
She was stabilized.
Yes, sir. Yes, sir.
At that time, she was receiving any inotropic or vasopressor support before taking her to surgery?
No, sir. No, sir.
So she was off inotrop, off vasopressor, isn't it?
Yes. Yes, sir.
In any time prior to surgery, have you used these drugs and inotrop vasopressors?
On day 1, sir. Not after that.
Not after that. Okay, so I feel that this patient, when she was taken for surgery, she was hemodynamically stable.
Yes, sir.
And she went, she developed this hemorrhagic shock because of loss of 4 liters of blood.
Yes, sir.
Okay. So it was a clear-cut case of hemorrhagic shock.
Yes, sir.
Now, hemorrhagic shock is managed by replacement of blood and IV fluid. You
Yes, sir.
have even given adequate replacement during and after the surgery.
Yes, sir.
And you have started noradrenaline also.
Yes, sir.
Now, despite doing all those things, patient kept on in the state of hypotension, and even after 24 hours, she has not regained her blood pressure, and she continues to be in hypotensive state with requiring a noradrenaline 10 microgram per kg per minute. Am I right?
Right, sir. Yes, sir.
So what are the reasons for this hypotension? Persistent hypotension. What was your differential diagnosis?
There can be myocardial depression, maybe the one reason, sir.
Patient was intubated. He was getting 100%
Yes.
oxygen.
Yes, sir.
He was on ventilator now.
Yes, sir.
Then why myocardial depression?
So because of acidosis can lead to
So show me the ABG. Post-op ABG.
Post-op APG has not put. Yeah, this
not, sir.
No, this is again a mistake.
Right. Yeah.
The patient is hypotensive, requiring inotropic support. Patient is on ventilator, and you have not done an ABG. Was it done or not?
It was done, sir, but it was not.
So was there any acidosis in that?
Yes, sir. There was acidosis, which was corrected.
How like was it like CO2 retention or metabolic?
Metabolic acidosis.
Can lactate levels and all?
Initially lactate levels were around 6, which was corrected with fluids and blood products.
So this ongoing bleeding patient, will you keep on giving fluid, or what is the problem in using more crystalloids in this group of patients who is still having a
So there will be
drain of
dilutional coagulopathy.
so there can be chance of dilutional coagulopathy. So it is better to avoid crystalloids and replace with blood and blood products. And obviously you will have to monitor other parameters either based on TEG or based on other coagulation profile. Then you will have to
Yes.
correct that as well. And what are the
Yes.
other problems of hypotension? You didn't answer that question.
So
One is
hypotension.
hemorrhagic shock you told. Next, what are the other causes of what may be the other causes of hypotension in this patient?
Immediately post main cause will be hemorrhagic this thing.
That you already told. Other than hemorrhagic shock, what are the other possible causes? This patient was on ventilator for almost 6 days. Then you
Yes,
took for the surgery. Initially, patient
sepsis
had
can be
hypotension.
there, sir.
Yeah.
Ventilator associated septic shock can be the cause, sir, because the lines were placed when if patient was on ventilator for 6 days.
Sepsis is one possibility. So obviously, if even after correcting the shock, sepsis is persisting, you have to send the cultures and maybe like we'll have to think about escalating antibiotics also. Then what are the
Yes.
other possibilities?
There can be since there was a right ventricular dysfunction. These patients are prone for right ventricular dysfunction, sir.
Right ventricular
that may be also cause.
will it produce such a severe shock? Other than that, one thing can be a pump failure, the cardiac dysfunction. So what are the
Right.
possibilities? Cardiac dysfunction, even if the previous ECG, echo, everything is normal.
See, whatever you are saying, you have not presented any evidence. Unless you do your diagnosis properly and suddenly, because see, now the ball is in your court. Surgeon has done his job. Ball is in your court. You have to take this patient out from the ventilator and send him back to the ward. So it is wholesale responsibility is yours. Now, if you are not able to make a proper differential diagnosis of this hypotension, because again, all these things are going to affect your outcome. Outcome means failure to wean. Failure to wean has got a direct relations with prolonged hypotension, long-term inotropic vasopressor use, huge blood loss. All things, these things are going to precipitate your outcome.
Yes, sir.
Are you getting my point?
Yes, sir.
So you have not given us the proper investigations which has been done immediately on day one postoperatively. Because this is the most crucial time. Don't you think that the first 48 hours after surgery is the most crucial time for any patient?
Right, sir.
So you should have gone in detail, because these 48 hours will decide for what is going to happen after 1 week. Okay, go ahead.
So on day 7 of admission, the noradrenaline was tapering, but required 7.6 max per kg per minute. Ventilation continued. Chest X-ray was better, showed a right homogeneous opacity suggestive of right lung collapse with pleural effusion. Diuretics added to keep negative balance. Right up position was given and chest physiotherapy started. Antibiotic upgraded to injection meropenem 1 gram and injection targocid 400 milligram IV after resending culture.
You started physiotherapy for this patient. What kind of analgesic and sedative you are using for this patient?
So analgesia injection fentanyl infusion was kept, sir, and for sedation injection midazolam was used.
Fentanyl and midazolam.
Infusion of midazolam, sir.
And fentanyl was SOS.
No, sir. Fentanyl infusion also was kept, sir.
Okay,
Patient was
fentanyl midazolam infusion.
Infusion, yes, sir.
Okay, then antibiotic, why you upgraded?
Because patient was still requiring noradrenaline, so and procalcitonin was 0.68, so antibiotics were upgraded.
Do you think a single value of procalcitonin 0.68 in a post-trauma malignant patient is significant?
No, sir. The procalcitonin will rise in post-trauma patient also.
So this procalcitonin may not be significant, and again, one value of procalcitonin is also not having much significance. You need a serial values which should show like an increasing trend. And what is the reason for adding targocid? Better to always put the generic name rather than the trade name. So what is the content of targocid?
Teicoplanin.
Why teicoplanin was added here?
So gram-positive cover was
Specifically teicoplanin, what gram-positive cover you are looking for?
methicillin resistant Staph aureus.
So this post-op like sepsis, how common is
Yes,
MRSA in your ICU?
we do get patients with methicillin resistant Staph aureus in our ICU.
MRSA like in post-op patients, MRSA bacteremia with MRSA bacteremia.
Is it very
Yes.
common in your ICU?
Not very common, but as the NORAD requirement was still there, so we empirically added it, sir.
Usually, like as per the Indian data, the MRSA incidence is very, very minimal. So all patients, even if they are going for like a sepsis like this patient, probably a gram-negative sepsis will be a common. And I don't personally feel we have to add MRSA coverage for all the patients. And okay, one more question at that point again. This teicoplanin, how will you usually give?
So
How many doses?
we 400 milligram, 400 milligram ODs once a day.
From day one onwards.
Yes, sir.
You don't need any other loading dose and all?
So 400 milligram on day 12th hourly on day 1 and 24th hourly on from day 2, sir.
Is it still followed, or is there any change in that practice nowadays? Any evidence change? That was the previous practice where you give only 3 doses of teicoplanin. Now the recommendation is you have to give at least for minimum 3 to 4 days. Then we will have to look at the trough levels. Okay, next one. Just one point I've added at that level. That's all. Yeah, proceed.
Day 8 of admission, 8 AM cortisol was sent in low persistent hypotension. Its value was 6. Injection hydrocort 100 milligram IV TDS was started and invasive lines were changed.
Just a minute here. What the guideline says, at what point of time you should add a steroid in patient who is in septic shock? So now I presume that you have made your diagnosis septic shock.
Yes, sir.
So at what dose, when it is the recommendation now, which has come in the form of guideline, that at what dose of norepinephrine you think of adding hydrocortisone?
So if the patient is on dual vasopressor and BP is still patient is still hypotensive, we need to add steroids, sir.
And do you check a 8 AM cortisol for all such patients?
No, sir.
So this is 8 AM cortisol. What grading it? What is the grading? It is 8 AM cortisol is now what level of recommendation it is? Have you seen that 8 AM cortisol has now been written in the recent recommendations of septic shock?
No, sir.
So was it necessary to send 8 AM cortisol?
No, sir.
So I was asking my question is that at what dose of norepinephrine you will think of adding hydrocortisone? And that is clearly a grade, almost I think it is grade 2 recommendation, if not grade 1. You said you have started to vasopressor.
So, so the guideline says that if BP is not maintained on 2 vasopressors, we should consider adding steroids.
So if somebody wants to continue with 1 vasopressor, then I think you need to revise your knowledge about guidelines.
Yes.
It says 25.25 microgram. That is the dose. Okay, it starts from 0.01, then 0.1, then 0.2 was the highest dose, and now it is 0.25. They say once it reaches 0.25 norepinephrine, at that point of time, you should think of adding hydrocortisone. That is what is there in the guideline. Okay.
What is the dose of hydrocortisone? Is it 100 milligram 8 hourly?
It is 50 milligram 4 times a day, sir.
Then why, like you're already suspecting a sepsis here, you are escalating the antibiotic. Then why you want to use such a high dose of hydrocortisone here? Well, what was the justification? Just tell. If you have a justification, you can tell that.
So the cortisol level was less, so it was
That's why in a septic patient, will you check a morning cortisol and give hydrocortisone? And even if it is, even if there is a low cortisol, is it the replacement cortisol usually we give?
so we give sir 50 milligram 4 times a day.
Okay, so you wanted to give a to cover for the severe stress response and go on for such a high dose. So that is your explanation.
Yes, sir.
Okay.
Okay.
So on day 9 of admission, noradrenaline support came down to 2.86 microgram per kg per minute. Patient was conscious, oriented, moving all 4 limbs. Weaning was started on pressure support CPAP mode with beep of 5 and pressure support of 12. Patient tolerated pressure support CPAP mode for 4 hours.
Just a minute.
There was no
Just a minute. Just a minute. So you have come down to noradrenaline of 2.86. What about your hydrocortisone? What about your
hydrocortisone was given, sir.
No, it was continued.
Day 9 we continued.
You continued with hydrocortisone, but in
Yes,
the
sir.
meantime, you have come to a micro dose of noradrenaline.
Yes, sir.
Is it the right way to do?
So what he is saying is like they have suspected an adrenal suppression at that point, and to cover that, they have started steroid, and patient was improving because of that, and they continued with that. That is his explanation, I think.
Fine, but okay, fine. Go ahead.
Patient tolerated pressure support CPAP mode for 4 hours. There was no CO2 retention on ABG, no tachycardia, no tachypnea. ET culture sensitive was suggestive of Pseudomonas. Day 10 of admission, the acetylcholine receptor antibody, anti-musk antibody, beta HCG and AFP came negative. Weaning trial was given with pressure support.
What was the sensitivity of that Pseudomonas? And what happened to the previous antibiotic, meropenem?
Meropenem was continued, sir.
Teicoplanin?
Teicoplanin was discontinued, but meropenem was continued.
So what was the sensitivity of Pseudomonas?
It was a sensitive strain, sir. It was sensitive to meropenem, so it was continued, sir.
What about sensitivity to other anti-pseudomonal BL-BLA combinations?
It was sensitive to piperacillin tazobactam also, but as the patient was improving, we continued with the meropenem.
Is it a correct dictum?
No, sir. We need to step down the antibiotic.
Okay, then.
So a weaning trial was given with pressure support CPAP mode with PEEP of 5 and pressure support of 12. Patient tolerated weaning trial well with pressure support of for 4 hours.
Your fentanyl midazolam is continued.
Midazolam was stopped, but fentanyl low dose was continued, sir.
You have not written anything. Your presentation is very incomplete, I tell you. You have not written anything because unless you write it, how will you understand?
That point is very important. No, like whenever you are after thoracotomy, when you are weaning a patient, adequate analgesia is very, very important. So what
Yes,
mode of analgesia you are continuing at that point is very important.
Continuous fentanyl infusion was going, sir, for the patient.
So at this point of time, What are the things which was continued with the patient?
Patient was on analgesics in the form of infusion fentanyl. Vasopressors were tapered, were in the tapering doses, and fluid was given, sir, and feeds were started.
Feed was started,
Yes, sir.
vasopressor continued,
On
steroid,
low dose, steroid continued, antibiotics continued, and fentanyl infusion.
And what was the oxygenation status at that point?
She was requiring FiO2 of 40%, on which she was maintaining saturation of around 98-99%.
What parameter you specifically look at to assess the oxygenation in
PF
ABGY?
ratios.
Okay, so how much was the PF ratio?
It was around 300, more than 300.
More than 300. Then why you want to keep an FiO2 of 40 there? Okay, then.
So patient conscious oriented, moving all four limbs, SpO2 98%, PLC to 30%, noradrenaline tapered off. ABG was suggestive of compensated respiratory acidosis. Spontaneous breathing trial with TPs was given for 2 hours. Patient was extubated to nasal prongs, but became tachypneic with respiratory rate of 40 per minute. Patient was kept on NIV, but she was not non-compliant with it. So she was kept on HFNC. Flow of 50% and FiO2 of 60, flow 50 liters per minute, FiO2 60%.
So what was, just a minute, what was the points on the basis of which you took a decision of extubating this patient?
So patient was conscious oriented, moving all four limbs, requiring oxygenation of maintaining saturation of 98%.
What level of motor response you would like to see before extubating? What level of motor response would you like to see?
Patient moving all four limbs, power 5/5 in all four limbs, sir.
5/5?
Yes, sir.
Okay. So other points?
Patient should be able to hold the neck, protrude tongue. Patient should be able to cough.
So you gave a spontaneous breathing trial.
Yes, sir.
And before that, you kept the patient on pressure support.
Pressure support. Yes, sir.
So on pressure support, what were the ventilatory parameters?
So PEEP of 5 and pressure support of 12 on FiO2 of 30% was kept for the.
No, I am interested in expired minute volume.
Expired minute volume was around 7 to 8 liters, sir. Minute ventilation.
Okay. No, expired minute volume was 7 to 8 liters. Okay.
Minute ventilation was around 7 to 8 liters.
And you put the patient on spontaneous breathing trial for 2 hours after that.
Yes, sir.
At that point of time, the patient was conscious, oriented,
Moving
well responsive, raising all the 4 limbs.
Yes, sir.
And his vital parameters were also normal.
Yes, sir.
So you took a decision to extubate. Go to the next slide.
So patient was tachypneic, respiratory rate of 40 per minute.
No,
tachycardia.
before this, one slide before. So here, your noradrenaline was stopped. The ABG was showing compensated respiratory acidosis. So what do you understand by this?
So there was PCO2 was on the higher side, but the pH was normal.
So do you think that PCO2 was it a normal finding or is it an abnormal finding?
This PCO2 on the higher side is abnormal.
It is abnormal.
Yes.
And it was being compensated. You have not put the complete ABG. Do you have the complete ABG? So what are the consequences of respiratory acidosis which can happen in the body?
So hyperventilation can be there.
So
That
you are
will
saying
cause
that
tachypnea.
So you are saying that respiratory rate was normal. So these two things are going in a contradictory direction, opposite direction. On the one hand, patient is in respiratory acidosis and you are saying that respiratory rate was normal. How it can be possible? Am I right?
Yes, sir.
So you yourself is telling, because I know that you might have made some manipulations as far as findings are concerned, because you are presenting a case. But in exams, if you do such kind of mistakes, you are gone. On the one hand, you are saying that patient is on compensated respiratory acidosis. And on the other hand, you are saying that his respiratory rate was normal. And on the basis of saturation, you take a decision of taking out the tube. And you gave a spontaneous breathing trial of 2 hours with a 4 liter of oxygen, despite knowing the fact that CO2 is high. Is it the correct way of going for
No,
weaning?
sir. No, sir.
So your approach is
Wrong, sir.
not correct. And you extubated the patient and you put it on nasal prongs. Nasal prong.
Is it the correct approach again?
No, sir. We should have put her on NIV.
Should have directly extubated the patient to NIV. And again, I think the TP trial also could have been avoided there. And the initial one during CPAP trial also, you should not have hyperoxygenated the patient with a compensated respiratory acidosis.
And what was the hurry of extubation in this patient? I failed to understand such a bad lung. Before assuring that and patient was just immediately you made him off from inotropic agent. Hello? Am I audible? Hello?
Yes, Anjana, you can, you want to add something?
Hello?
Anjana, are you there?
Non-balance support was Hello.
Yeah.
Your voice is not clear.
Hello.
Yes. Your voice is not clear. I'm breaking with your voice.
Okay, Dr. Ganesh, you proceed.
You proceed, you proceed.
On day 12, patient was tachypnic, respiratory rate 40 per minute, tachycardia, heart rate of 110 per minute, desaturating on HFNC to 89%. So reintubated and bronchoscopy was done. So
what happened on day 12? Just a minute. Let me see again. Patient was tachypnic, respiratory rate is 40. So obviously it was quite expected. And his respiratory pulse rate was 110, desaturating. Again, this is very difficult to explain. If he was maintaining on TPs a 98% saturation with a PO2, you are saying going up to 300, it is difficult to explain desaturation, but I understand that probably the patient has not been able to maintain his cough reflexes properly, so might he have aspirated with his own secretions.
yes, sir.
So reintubated the patient and a bronchoscopy was done. Okay, what happened after that?
So these are the X-rays of the pre-intubation and post-intubation.
Okay, so you mean to say that patient might have gone into reabsorption collapse?
Yes, re-expansion pulmonary edema.
The The re-expansion pulmonary, what is that? Re-expansion pulmonary edema? Can you tell me the detailed pathophysiology?
When the lung volumes expand, there is a sudden rise in the intrapleural the blood supply increases due to the negative pressure due to the leak due to the increased pressure there is extravasation of the into the alveoli.
So here this patient who is on like you have done the surgery, pleural fluid was drained, the patient was on ventilator for 5 days, then you are extubating, then why you want to suspect a re-expansion pulmonary edema? In which context you usually get that re-expansion pulmonary edema?
When we there is sudden expansion of the
Whenever you have a
lung
massive
parenchyma.
pleural effusion or something and you completely drain it immediately, so that is a situation where the lung expands. And so that point you can get. Other than that, this patient already on ventilator, you have already drained. The post-op X-ray is showing a very good clearance because it's
Phase 2 was there for 5 days, isn't it? On 5th day, you surgery was done, na?
Yes, sir.
So phase 2 was there for 5 days.
Now, why you can explain, Ganesh, like why the re-expansion pulmonary edema was suspected?
So, because suddenly there was post-extubation patient became tachypneic and tachycardic with there was X-ray was suggestive of collection on the right side.
So it is so you mean like patient is going for a unilateral re-expansion pulmonary edema here. So this see the X-ray picture itself. One side lung is left side is completely clear, and you have a right side opacity. So what are the
Yes.
possibilities in this case, other than
So
pulmonary edema?
there can be collapse, consolidation.
Okay.
Then
Or there
pleural
can be again a collection happening there, which is
effusion.
again collapsing the lung. Or
Yes.
definitely, or you might have aspirated or like you might have developed a pneumonia, and that may be progressing because you have not shown the serial X-ray. And you have
Yes.
not mentioned whether the patient had a temperature spikes or any fever of a like any features of a ventilator-associated pneumonia. So
So
with
you
this,
did a bronchoscopy. What was the finding of bronchoscopy?
So bronchoscopy was normal, sir. There was
Bronchoscopy was normal.
Sir, can I answer?
Yes, yes.
Sir, bronchoscopy rule out any right collapse, sir. So,
Again, your voice is breaking.
sucked
Please
out
make
with
your voice is breaking, madam.
Okay, sir.
Please make your internet connection stable.
So bronchoscopy was done. There was no collapse of the right lung at that time.
Okay.
There were secretions with the bronchoscope.
and what was the
Secretion-
indication to do a bronchoscopy at that point of time, immediately after intubation?
Sir, we wanted to rule out any right lung collapse because
So you
the
have
X-ray
decided.
was suggestive of a.
So you have decided the bronchoscopy after seeing that X-ray.
Yes, sir.
Okay, fine. That's very good. Yeah.
Hmm.
So that you have to tell like that. See Ganesh, how they have
That is
explained.
the problem. Na? Sequence was not correct. He said ki bronchoscopy was done. You should have told that yes, first X-ray was done. This is the finding of X-ray. On the basis of X-ray finding, we went for a bronchoscopy, presuming that it is an obstructive collapse. That is how you should tell the examiner.
And again, you should have never told about re-expansion pulmonary edema at this point, because that was not at all a point of consideration here.
Yes.
Okay, sir.
So what you did?
Okay, proceed, Ganesh or
Proceed, Ganesh.
Anjana, whoever wants to proceed, please.
So this was the chest, the X-ray on the right side was the chest X-ray post intubation. So we did a bronchoscopy after intubation to rule out a right lung collapse.
Okay.
Madam, you are also a student also.
I'm a DNB resident, sir.
You are a consultant or you are a student?
So she is
No,
also
sir.
a DRNB
Student, sir.
resident.
She is also a DNB resident. So why you came to patch up Dr. Ganesh?
They both were presenting actually, sir. In
Huh?
fact, no, they both were
Yes, sir,
supposed to
initially, so
present.
there was problem.
Some network issue. She was not able to join.
Okay, man, the same case, both were supposed to be there.
Yeah, they were like
Yes.
supposed to present together.
Okay, fine, that's fine. Then it is fine. I thought he is.
I think Ganesh was not prepared for the first part, I feel. So,
Okay.
Actually, sir, the case was taken by Dr. Anjana. I was in other ICU. So basically,
Anyway, Ganesh, when you prepare, you should be thorough.
yeah, that is.
That is not an excuse for an examiner.
wait.
That
Sorry,
is not an excuse. So,
So now, Anjana, it's your turn. So now you can take over and continue. Because
Okay,
Ganesh is already drinking water from there. So you can continue.
Okay, sir. So next slide, please.
Next, Ganesh, you will
Next
have
slide,
to
please.
change the
Dr.
so what you did, you intubated the patient and put the patient on ventilator again.
Yes, sir.
Yes. So what about this right? You are not commenting anything about right X-ray on the right side.
Sir, since we
There are
suspected
sounds which is
right,
coming from your background. Can you ask if hello?
sir, yes, sir.
There are noise which is coming from your background.
Okay, sir. So since we suspected a right lung collapse, we gave her an right up position. We did chest physiotherapy for her, and we did the X-ray on the right side is the chest X-ray post chest physio right up position and bronchoscopy.
Where are the slides?
Dr. Ganesh, can you please move on to the next slide?
Now I'll share from here, don't worry. So now where did we reach?
That X-ray slide with two X-rays.
I'll share from here. Okay. Slide, this is okay. This is fine now. Jana?
Yes, sir.
Okay, so this one, okay, this one. Okay, continue. Anjana, please continue.
Sir, so on day 13 of admission, we continued her on controlled mode ventilation. 2D echo was repeated, which showed a normal EF of 55 to 60%. There was no regional wall motion abnormality. There was no right atrial or right ventricular dilatation. We continued her on diuretics because
1 minute. Initially itself we discussed a
we thought
patient.
that she had a probable expansion pulmonary edema. We wanted to keep her negative, so we continued her on diuretics.
No, Dr. Anjana, 1 minute. This patient, what was the?
She had. Sir?
No, previously itself we discussed that this patient had a chronic type 2 respiratory failure, breathing difficulty for almost 1 year duration, and still you expect no pulmonary hypertension at that point or immediately resolved after post-op, it's very, very unlikely.
Sir, the official 2D, she should have had a pulmonary artery hypertension, sir, but the official 2D echo done did not show any finding.
No, it's very unlikely. Okay, then.
So on day 14 of ventilation due to prolonged weaning, we did a tracheostomy. The urine and blood cultures we sent earlier showed no growth. So the bowel culture that we sent during bronchoscopy grew Klebsiella and Pseudomonas.
So what do you think? What was the reason of failure to wean?
So one is she would have had a inherent respiratory muscle dysfunction that contributed to a type 2 respiratory failure. That would have been one reason, sir. And
Why?
Because of the intrathoracic tumor.
So this intrathoracic, you told it's something like a mesothelioma, no? So
Yes,
that
sir.
is, will it produce a muscle weakness?
But as per Ganesh, the patient's motor power and everything was absolutely normal before taking out the tube.
Yes, sir.
So how come it happened immediately after extubation? How can you explain that?
Dr. Anjana, tell the common causes. Here you
Yes,
have
sir.
X-ray, all those things. So what are the common issues here? Weaning issues. In this patient who was operated, was on ventilation, received a multiple transfusion, had chronic type 2 respiratory failure. So such patient, other than like the inherent muscle weakness, what are the other issues?
She would have had a she had endocrine disturbances. She had low cortisol, so that would have been a reason. She would have had ventilator-induced diaphragmatic dysfunction.
Ventilator-induced diaphragmatic dysfunction. So what the evidence says about VIDD? After how many days it occur? And what is the percentage of weaning failure because of VIDD? After how many days?
Sir, no
Or how
idea.
will you usually assess VIDD?
We can use an ultrasonography to see
What
the
is
diaphragmatic excursion.
What is the finding on ultrasonography for ventilator-induced diaphragmatic dysfunction?
The diaphragmatic excursion will be less than 10 millimeters.
Diaphragmatic excursion will be 10 then. So have you seen any literature which suggests that if the diaphragmatic excursion is less than 10 millimeter, they are the cases of weaning failure? Have you gone through any literature?
No, sir.
Then it is your presumption.
Sir, according to reference from Irwin and Rupe,
It is your presumption or it is evidence-based?
it is evidence-based, sir.
What it says?
So, if the diaphragmatic excursion is found to be less than 10 millimeters, there are chances of weaning failure.
Have you gone through any literature?
Literature, no, sir.
So how you say that it is evidence-based? Because it is written in the book. I don't see that the patient who is just for 5 days on ventilator has developed. So it will be very difficult to explain those patients who stays for months together on ventilator and they come out easily.
Okay, sir.
No, other than that, Dr. Anjana, this patient who had already had a thoracotomy, a tumor excision, what other diaphragm issues you would have expected this patient routinely?
During a procedure, there would have been a diaphragmatic rent that would have caused diaphragmatic weakness.
How that can have happened? Like their diaphragmatic rent is the least possibility. Other than that, anything
injury to phrenic nerve.
Yeah. So what can it cause? So unilateral.
So it will there will be
Unilateral
Chronic no
diaphragmatic dysfunction
injury
may be
can
a
be there.
possibility at that point. So after the lung expansion, you have to see, and with ultrasound also you can assess whether that diaphragm is moving or not.
Okay, sir.
Other than ultrasound, what other option you have to look for the diaphragmatic palsy there?
Paradoxical bridging will be there, sir, clinically.
This ventilated patient, how can you make out that? So under
There will be sorry, sir.
fluoroscopy also you can see whether how the diaphragm moves with the respiration.
Okay, sir.
So that is one common possibility you have to consider always whenever you have a weaning failure for such post-operative patients.
Okay, sir.
Then what are the other issues? Rather than looking for the rarest causes, think about common causes here. Dr. Ganesh, you can also add.
Yes, sir. So nutrition, electrolyte imbalance can be there, sir. Hypophosphatemia can cause for.
That actually we have checked all the electrolytes, no? Like patient is already in the
Yes, sir.
ICU. The pre-op
Yes,
also
sir.
we have checked everything. So it's very unlikely. Other than that, the nutritional issues, what are the issues you expect here? A patient with a malignancy, maybe with symptoms for more than 1 year.
So there can be refeeding, there can be electrolyte imbalance, hypoalbuminemia.
Hypoalbuminemia.
Cancer cachexia is a possibility here. There may be
Yes, sir.
undernourished from before itself. So, and
Yes,
they
sir.
can be having a muscle weakness because of that. Then, what are the other possibilities? Like we have sir has discussed initially itself. Now, this patient post-thoracotomy, whether analgesia was adequate with this patient, or after extubation, what analgesia were continued. If the analgesia is not adequate, again, patient can have may not be able to breathe properly, may not be able to cough out properly. That can also contribute to again lung infection. Then this patient has already received multiple transfusions. So that also is again like a possibility, or will increase the chance for ventilator associated pneumonia. Then whether the fluid balance is correct. So what is deresuscitation? Then Ross concept.
So initially, Rose concept is we resuscitate the patient and optimize the patient, stabilize, and then de-resuscitate the patient. We try to keep the negative balance.
So this patient, you would have also mentioned about the fluid balance, whether the cumulative balance, how was the cumulative balance, how was the urine output, whether we were able to attain at least a negative fluid balance, even though if you're not able to attain a negative fluid balance. But this patient is already hypotensive, you said, no? Or hypertension improved?
You have not mentioned about, at this point of time, what was the status of your, after first extubation, what was the status of your inotropic, steroid, all those things which were giving IV? You have not mentioned anywhere. Whether they were still continued or they were stopped, what happened to all those things? Ganesh, are they continued or they were stopped?
They were stopped, sir. They were stopped. Noradrenaline was tapered. Steroids were stopped.
They were stopped. So steroid was also stopped immediately from 400 milligram to 0 milligram?
No, they were hydrocort was tapered and then stopped, sir.
Hydrocortisone was tapered, and so on what day it was stopped?
Sir,
Okay, tell me what are the, to come to the point. I know that your proper collection is not there as far as data is concerned for this patient. Tell me what are the protocols which you follow for weaning?
So we initially assess the patient for the readiness to wean. Basically the cause for which the patient was intubated, whether it has been resolved or not. Then we assess the plot readiness for the weaning. We see some criteria that patient is clinically stable, hemodynamically stable,
Tell me
maintaining
the clinical signs of respiratory system on the basis of which you will decide to wean.
the respiratory rate should be less than 25 per minute. The PF ratio should be more than 200.
Clinical signs. Stick to the clinical signs.
Okay. Patient is conscious, oriented, moving all four limbs. Patient is having no tachypnea, no tachycardia. No fever is present.
Clinical signs of respiratory system.
Absence of tachypnea, sir.
No tachypnea. He should be able to cough out the secretions.
Cough out. Yes. This is which I wanted to listen, because cough reflex is one thing which actually decides whether the patient will sustain extubation or not. And secondly, adequacy of, when you are trying with a pressure support or CPAP, you have to see the adequacy of minute ventilation. So what do you feel? A patient who has got one-sided lung is totally shadowed. How much minute ventilation do you expect in this patient?
Around 5 to 6 liters per minute.
5 to 6 liters per minute. And what should be the pH of this on ABG? What kind
pH
of
should be
pH
more
do you
than
expect?
7.35.
7.35. Why not 7.36? Why not 7.34?
So basically, there should not be any acidosis.
There should not be any acidosis. Do you think that you will be able to prevent acidosis if only one lung is working? 100% prevention of acidosis, respiratory acidosis? Is it possible in a patient who was severely hypotensive preoperatively, went through 5 days of ventilation, was on hypotension for so long, was having hemorrhagic shock, received so many blood transfusion? So do you presume that this patient will develop an absolutely behavior like a normal lung?
No, sir.
So what are the expected findings? What are the expected findings? Suppose this patient has got only one lung as a functional lung. What are the expected findings you will see before extubation? What should be the status of carbon dioxide? Do you feel that
Permissive hypercapnia can be taught, accepted, sir. pH 7 more than 7.25.
Okay, so that is important. Another, anything else?
Oxygenation status, PaO2 should be more than 60, 70.
So you have to, main thing is that you have to compromise as far as normal oxygenation is concerned. You have to compromise a little bit as far as carbon dioxide is concerned. You have to compromise as far as minute ventilation is concerned. You have to compromise a little bit as far as whole ABG is concerned. Are you getting my point?
Yes, sir.
Okay.
Yes, sir.
So now tell me at what are the safe levels at which you will decide that yes, now this patient can be extubated. Your findings are, only thing which you have written in this slide is saturation, which is 98% with an FiO2 of 30%. And you have not mentioned anything other than this as far as clinical findings are concerned or lab findings are concerned in this slide.
Okay, Ganesh, you can just mention about the common weaning indices and how you assess the readiness for weaning. Usually, you forget about this case.
Yes.
Winning indices which we assess are like PF ratio is seen, sir. Respiratory rate is seen. Respiratory rate should be less than 25 per minute. PF ratio should be more than 200 mm on FiO2 of 0.4. Then RSPI, rapid shallow breathing index, is calculated, which should be less than 105. And then
Is it
there
RSBI is
are
applicable with one lung? Rapid shallow breathing index is it applicable in a one lung?
it is studied on to not validated for one.
Okay, go ahead. You tell all other things which you like to see.
Uh, then there are some index like crop index and core index. Crop index should be more than 13 and core index should be more than 8, which suggests that patient can be weaned off the ventilator. There is integrated weaning index, which should be more than 25.
What is that?
There is integrated weaning index consists of it is a product of compliance into compliance compliance into saturation of divided by rapid shallow breathing index.
And what is the normal value?
More than 25 indicates that the patient is we can wean the patients.
More than 25.
Yes, sir.
So you did all this calculation for this patient?
No, sir. This according to the literature.
So I am asking because you are telling me the theory now. Because whatever you say, at least you should say that yes, some of those you have practiced with this patient, or so some of those you have applied for this patient. Have you applied
So
few things?
P.1.
We have applied, sir, rapid shallow breathing index P.01 and static and dynamic compliance, sir, for this patient. We have a table after 2-3 slides.
Okay. So show me the slide. Where is the slide? Okay, fine. So so all these things were normal, isn't it?
Yes, sir.
Yes, sir.
So you decided to extubate, and what happened after that? But the compliance is acceptable. Is this compliance is acceptable? Is this compliance is acceptable?
So compliance was around 27-30, sir.
What is the normal compliance when you measure it?
50, sir, more than 50 ml per centimeter of H2.
So you're on 4 days, that is 13th, when you are trying to extubate the patient, it is 27.
Yes, sir.
So what happened after extubation? So you took a decision of extubating the patient?
No, sir, patient was tracheostomized. Sir.
Patient was tracheostomized. Show me the next slide.
So now the patient.
Sir, actually extubation was done on 6th of December. So we have the weaning indices on 5th of December.
No, that's fine. So you have put the patient on TPs after that. You didn't go for direct extubation because you had a like extubation failure before.
Yes, sir.
Or in general, like what are the patients you usually like keep on tracheostomy, even with a normal sensorium?
difficult to if the patient is difficult to intubate, so we can go for tracheostomy.
It's very unlikely situation in an ICU. Other than that, for any upper airway obstruction, okay, fine.
Patient in
Like
which we
if a
suspect
patient is having an ongoing,
risk.
ongoing lung issue, or especially the neurological complications where the patient sensorium is not improving, or like if the muscle weakness is still persisting. So this patient, that is a one point you have to mention, whether the patient are already having a critical illness myopathy. So that may be the other reason. And again, how the nutrition was tackled for this patient, though those points can be mentioned. And what are the usual issues with the like weaning failure? Forget about this case. The normal, the weaning failure issues. The causes of weaning failure normally.
So that can be due to increased secretions, increased airway resistance. There can be due to underlying undiagnosed cardiac causes.
How usually we can classify that, the weaning failure?
So
Sir,
ABCD.
A for
Airway.
airway or lung, B for brain dysfunction, C for cardiac dysfunction,
Cardiac.
D for
Or basically,
for-
you can have a neurological issues, or you can have a respiratory issues.
yes, sir.
That respiratory, you can again have a lung related issues, or you can have a muscle related issues, or even cardiac related issues can be there. Even the compliance issues can be because of all those things. So you
Yes,
have to assess all those things, and then we will have to optimize that. Even the neurological status is also very important. What are the main issues with weaning failure, with the neurological problems?
So delirium can be there.
Yeah. So
Sleep awake cycle disturbance.
okay, so you will have to optimize that. You will have to assess the how will you assess the delirium and all?
CAM IC.
By CAM IC.
Yeah, so we'll have to assess the delirium. We'll have to optimize that. Then see other neurological issues. The same way the respiratory problems as well, and especially a patient with a CO2 retention already on tracheostomy. If you want to wean the patient on tracheostomy, what other things you could have done other than putting the patient on a TPs? If you like the patient you don't want to keep the patient in the ICU for a prolonged time, you want to shift the patient to the room. So do you have any other option like other than putting a tracheostomy tube?
There are many a few new modes which has come up. Do you have any knowledge about those? They are used for weaning difficult to wean patients.
Yes, so automated systems can be used like NAVA, neurally adjusted ventilatory assist, and adaptive support ventilation.
NAVA, ATC, automated tube compensation, and third is proportional assist ventilation. Proportional assist ventilation. So these are the three modes which you can use for weaning a patient, difficult to wean patients. They have been found to be useful, although literatures are very few, but still lots of work is going on. Okay. And yes, so this was a case who was difficult to wean because of 1, 2, 3, 4, 5 reasons. You tell me, what are the reasons?
First of all, this was a one lung ventilation, a single lung case with underlying malignancy. So nutritional issues will be maybe there.
No,
there was massive transfusion.
You tell me relevant to your patient. Your patient. Don't say what is written in the book, because if you see the book, there are 20 points. Relevant to your patients, you tell me 5 points which were actually hindrance to the weaning from ventilator for this patient.
So one lung ventilation, decreased cortisol levels,
hypoalbuminemia.
hypoalbuminemia.
Anything else? 3 points. You just told us 3 points. One is right. There was a lesion in the lung.
Yes, sir.
Second, the one important point, as I said in the beginning, the patient went to hemorrhagic shock and she lost 4 or 5 liters of blood. So don't you think that these are the reasons which will also contribute to failure to win? And you have given a massive
Yes, sir.
transfusion.
Yes, sir.
So you have to add all those things when you are telling. When you are summarizing, you have to see the whole case from the time when he came to the ICU until the point of final winning. Are you getting my point?
Yes, sir.
Yes, sir.
So in that way, how many points you can calculate?
Like the pre-op issues, but like what are the immediate post-op, what are the issues in the ICU, what were the issues contributing to the weaning failure? That is what sir is asking. So the pre-op, what were the issues?
Pre-op, sir, lung mass was there with underlying collapse of the lung parenchyma.
There was a volume reduction and a chronic
Volume reduction.
respiratory failure. Then,
And
as you mentioned, the nutritional issues, maybe because of malignant.
Underlying
Then again,
cancer kicks.
yeah.
Then intra-op, there was massive blood
Massive
loss.
blood
So
loss.
anemia can be one of the cause for the anemia with
Massive transfusion, fluid overload related to that.
fluid overload.
Yeah.
Yes.
Then
re-intubation it itself is a very bad
Yeah.
marker for outcome. Re-intubation. You did a re-intubation to this patient, isn't it? So it's a bad quality
Yes,
indicator. It's a bad quality indicator. Outcomes usually those patients who get re-intubated are usually bad. That's why that should also be counted.
Okay, sir.
Okay.
Okay, sir.
So Venkat,
So yeah, I think most of the areas were covered by both of you. I think Anjana, you had some background noise that probably was disturbing you.
Yes,
So most of the time, sir, the case may be different, but the weaning failure is a common challenge which we commonly encountered in many of our ICU, maybe from different reason. As all of you pointed out, the readiness to wean is one component, then weaning protocol is the second component. The third one is the extubation, the three processes which you all explained to them. And as you pointed out, the clinical criteria are different, where the disease for which the patient has been intubated. In this case, I think it is electively intubated for a lesion and that for a surgical procedure which is undergone later. And the patient also was having a respiratory failure. Other than that, as you said, optimization of from head to toe, that neurological status, cardiovascular status, oxygenation status, ventilation status, airway protection, and power, and probably respiratory muscle. In this case, as you rightly pointed out, this was a special case. Most of the times, hardly we come across the thoracic surgeries as a common cases in our ICU. But yes, as you said, most of the times when you have such cases in your ICU, we may get as a case for the exam. But the other situations we commonly encountered, sir, the patient who was on a prolonged period of ventilation. We see cases who actually get ventilated for less than 24 hours. Few cases we ventilate between 1 to 10 days. Few cases get ventilated for more than 10 days. And the reasons for there may be different, like a patient who are pneumonic, ARDS, requiring prone ventilation. So which are the patients who land up in critical illness polyneuromyopathy, muscle weakness, neuronal weakness, diaphragmatic weakness, and because of this steroid use in between. So a big list of things, and most of the things which you explained them. And many of the times these indices, which actually you pointed out after the clinical criterias, we look for these indices, at least swallow breathing index, which is the common one, P0.1 occlusion test with positive inspiratory pressure, tidal volumes, minute ventilation, and compliance, reactive airway. And most of the times, as you both pointed out, in these cardiac cases, the right heart failure or a diastolic failure is sometimes been also missed and ignored. And in this case, as I agree with both of you, there may be a area where it is screened by a junior colleague and maybe missed, but right heart with so much of lung lesion for a chronic period may be an issue of concern. Even though dyselectrolemia may not be an acute condition, but we do see hypophosphatemia as a challenge in many of these chronic patients, sir. And neuromuscular blocking, I think in this case, if I am not wrong, some of the the lung tumors, small cell carcinomas and other tumors do have a tendency of creating this myasthenia-like criteria by releasing this acetylcholine receptor antagonism or a mask-like receptors. So sometimes these tumors do behave or can be in etiology like a thymoma. Any comments on that?
syndrome.
Yeah,
Paraneoplastic.
paraneoplastic myasthenic phenomenon can be a phenomenon. Maybe that is the reason why they considered both musk and anticholinesterase levels there. Probably we need, as you said, whatever you do, you need to justify that. Mostly this is a possible reason why they considered. And the initial point is this patient presented to us with a ventilatory failure, CO2 retention. And there was also type 2 respiratory failure. So both probably we were initially thinking about an obstructive phenomenon. So if there was no obstruction, if there is a ventilation issue, is there any neuromuscular involvement in this case? So maybe that's another area which they actually thought in this case during this tumor workup. But as you rightly pointed out, sir, most of the times clinically there was no evidence of suggesting there is any myasthenia. So in this case, when we see a prolonged cases, maybe nerve conduction study, neuromuscular workup like repeated nerve stimulation state, those may be useful when we need to evaluate which part is involved, sir, from maybe CNS to nerve and muscle component, even EMG like electromyography, nerve conduction study, repeated nerve stimulation, those all will be also a component in a chronically ventilated patient. And is there any new data, sir, any lights on diaphragmatic stimulation being another area and using ultrasound as a kind of a diagnostic tool for diaphragmatic excursion and strengthening and seeing the weakness? In this case, as both the students pointed out, the diaphragm phrenic nerve involvement and injury can be expected in some of them. But any lights on the phrenic nerve stimulation? Anup, any comments, Pradeep sir?
No, I saw that people have done some of the studies, and I saw that they're being presented in the European Society ESICM conference, but none of them came out with a conclusion of a positive outcome after giving diaphragmatic stimulation to these kind of patients who are suspected of developing diaphragmatic atrophy or something like that. So I think still we are waiting to get a good trial to suggest that actually this modality of diaphragmatic stimulation actually helps these patients to get weaned from the ventilator. So till date, we do not have anything, but trials are definitely going on.
Sir, as you right,
Actually know like how to assess diaphragmatic function as sir has asked with ultrasound. So that part definitely for weaning a patient with a weaning failure and all when we discuss. So that part also should have been highlighted, and definitely we should go back and read those parameters. Right heart function, how will you assess? Pulmonary hypertension, how will you assess? Then diastolic dysfunction, then the diaphragmatic function, all those things, because ultrasound is a very common device and routinely used in ICUs nowadays.
You see, actually, Venkat, this was a very complicated case.
Yes.
From the point of view, see, his medical problem, keep apart.
Yes.
His surgical issues, keep apart. Then, because of such a huge lesion in the lung, the cardiovascular dynamics, those were also responsible. Then all the secondary effects which arises because of the tumor, they are also important. And then surgery itself is a big trauma. So surgery, and then this patient went to a hypovolemic hemorrhagic shock. So again, metabolic disturbances because of that, acid-based disturbances because of that. So there are number of
Yeah.
paradigms or aspects on which angles on which we can discuss this patient. So obviously, each of these dimension has got a huge scope for discussion. But from the point of view of a student, they should know at least I feel one of the important thing in this case is that these students, whenever they are presenting these cases, they should at least sequentially document the things properly, because documentation was not good. They prepared the slides, but the sequence somehow was missing, one after another. That was one thing which I observed. But you are learning, you are going for exams, you will be preparing for exams. So even if you write, when you are writing on your notebook or when you are preparing those cases, don't miss the important links, because doing an ABG, doing an X-ray, about IV fluid, about inotrop, about everything has to be when somebody looks at your documentation, he should see the continuity being maintained. So because of lack of continuity, there are so many questions which arose in between. But I think that all those questions will be helpful for you for
Yes.
preparing for your exams.
Yes.
But obviously, I think both these students, they have done very well, and to their best, they have prepared. And they have just the beginning. It is a beginning of their career as far as critical care is concerned. So
Yeah,
we
Pawan,
asked so many tough
Pawan,
questions.
Pawan, just see where from the noise is coming. There is a lot of background noise.
1 moment.
Please, other than Ganesh and Anjana, please mute others now.
Sure.
So Anjana and Ganesh, you can actually come on to the with your videos on and audios on. So as now we have come to a conclusion or the end of this session. This is a complex case, as we all understand, and this case has some speciality, and this case has some challenges, has been very well elucidated and pointed out by both the speakers or both the moderators. But in general, we may have a different weaning challenges in our regular ICU practice, and the weaning failure is can be a long case for you. So there were some questions in the chat box, sir, which I will just try to take. There were some questions related to some endocrinopathies, which can also be a list when we actually evaluate a weaning challenge. There were questions related to hypothyroid, whether the thyroid profile need to be then. We sometimes also look for a cortisol level. So endocrinopathies also can cause a weaning challenge and muscle weakness. Any comments on that, sir?
No, agreed. It is an important hypothyroidism. Definitely creates a problem in weaning, and the reasons are quite obvious, because hypothyroidism has got a direct link with the cardiac function and myocardial suppression. Many times these patients present with hypertension, heart failure also, and when they are in a stressful situation. And secondly, it is not endocrine system, as it has got effect on muscles. Not only it is the muscular system, I mean to say, the muscular system, because musculoskeletal system, because these patients are usually, they are cold, lethargic, and hypothermia is another important thing which develops in patients with hypothyroidism. So endocrinopathies as such, any kind of endocrinopathies have some directly or indirectly have got some effect on weaning.
Yeah. So I think that's a fairly, yes, sir, appropriate explanation for that. So you will look into endocrinopathies when they are in clinical context as suspected in weaning difficulties. There were questions related to the weaning trials and attempts. So the simple weaning, a complex weaning, or a difficult weaning, we define it by 1 attempt, more than 3 attempts, and it takes more than 7 to 10 days as a difficult weaning. So the question was, when do we actually consider tracheostomy After how many weanings you want to take, Dr. Anup?
Yeah, there is nothing like how many times. It depends on the case we'll have to decide. Suppose if it is a neurological or neuromuscular issues, and if you anticipate that it is going to persist, definitely you will have to go ahead with an earlier tracheostomy. Or the patient like this who has already failed, still having a lung issues, may not be able to cough out the secretions properly. Again, in that case also we will have to consider. So it is the multiple clinical points we will have to take together and we'll have to make a decision. And again, there is always a discussion about early tracheostomy, late tracheostomy, etc. So usually, we wait for almost a week or so. Like if we think that it is there are reversible causes. If it is not so, like if maybe some head injury patient or maybe a neuromuscular complication patients, etc., we may have to even go for an early tracheostomy. There is nothing like how many how many number of weaning failure should be there before considering a tracheostomy. That is a most practical approach, I feel.
There were questions related to PEEP. I think Dr. Pradeep has answered them on the chat box. There were questions related to ICU acquired weakness. How do we deal and effect of weaning and outcome? Pradeep sir, you wanted to take on that? The risk factors and
ICU acquired weakness, it is a very vague term actually, what I see, and there is no magic bullet which you can fire just to take care of this issue. Because weakness as such, you have to see many things. And first of all, the most important thing is when the patient came to ICU, what are the past status of the patient? Whether first of all you see whether it is a surgical case, whether it is a medical case, then pre-existing morbid condition, pre-existing patient has undergone some major surgery. What was the pre-existing nutritional status of the patient? The chronicity of the disease is also important. Then what happens? Your treatment, the pattern of treatment which the patient has received previously, and the pattern of treatment which the patient is receiving during the ICU stay. Then in the ICU, you see, as Dr. Anup said, duration of mechanical ventilation. That is one of the important point, obviously. But duration doesn't always affect, because many young patients whom you see come in the form with a head injury, they stays on the ventilator for months together and they come out very fast once you see that neurological status has improved. But on the other hand, if you see a case of major GI surgery who has come more than 65 years of age, and even if you see that things are okay, in another couple of days you try to win, but you see that there is a win failure. And all those things, because these are some of the examples which I am giving, it is not an easy thing to describe the whole lot of acquired weaknesses in one go. Because as we were discussing, there may be endocrine problem. Because of this endocrine issues, there are metabolic problem. There may be changes, alteration in the arterial blood gases, pH, acid-base balances. There may be changes in the temperature variations, maintenance of core temperature in the ICU. That is also a very important thing, because many a times we don't put our eyes on the temperature issues in the. But what we believe, because when we started our career as far as intensive care is concerned, before 2000, when we got our training, at that time the concepts were very poor, but we used to focus on 4 or 5 basic things. And one of the most important thing was the body temperature. So my teacher always used to say, put a probe in the rectum or put a probe in the nasopharynx and see the core temperature, and try to maintain the core temperature to its normal. If you do that thing, many times what happens that you succeed to avoid this acid-base imbalance, which happens because of sudden fluid losses or sudden hemorrhages, or because of sudden fluid leakages from some side. So all those things can be avoided if you, and all those are interrelated causes because of these issues. So ICU acquired weakness, it is not a one thing. It covers a huge number of conditions which can lead to this happening of this condition, weakness. Then I tell you, there are many patients who will see that when they are admitted in ICU, they are having good nutritional status. But suddenly what happens that some critical event happens in the ICU, and these patients develop a very patient conditions like DIC suddenly, and usually commonly it has been seen with patient surgical cases, suddenly goes into DIC and septic shock. And when they comes back, you see that after 10 or 15 days, the kind of weaknesses which they have, it is very difficult to explain that why it has happened. So it is myoneuropathy, what we see in the literature. It is the most simplified form of explaining these ICU-acquired weaknesses. But as such, when we look into the depth of this condition, you find that it is not so easy to explain these conditions. And that is why I say many a times that the Glasgow Coma Scale, which we commonly use for trauma patients, and we try to evaluate the patient, the motor response, you see many of the times that patient is opening his eyes, he's obeying commands, he is showing his tongue, but he is not able to move his limbs. So that is a very common state of affair in ICU. So how will you define, how will you put this kind of patients in your scoring of Glasgow Coma Scale? Your motor response is M1. You will describe, when you have to describe these patients, you will say a patient is in M1 state. But on the other hand, you see that he is moving his head, he is opening his eyes, he is showing his tongue, but he cannot move his all four limbs. So explaining these conditions are also very difficult. So it is a very complex process, inclusive of all metabolic, electrolyte, acid balance, temperature, everything. So the best technique is that every day, rather every shift, whenever you come and see the patient, you first of all, you see these basic things of the patients, whether they are in right position or not. Then, and if you try and maintain all these basic things which I just now described to its normal in every shift, then definitely I'm sure that most of these patients you can prevent going them to ICU-acquired weaknesses.
Yes, sir. I think you actually covered all those areas, sir. More than just a critical illness, the severity of illness, the nutritional status, the high catabolic state, as you said, some major event and loss of muscle mass, and that also risk factors like prolonged use of muscle relaxant, higher dose of steroids, immobility, all this can cumulatively can lead to further deterioration on that, other than all the evaluation which you made. Dr. Anup, there were actually questions related to two parts. Like one is, we as a clinicians go to the bedside and take a decision, this patient looks like we can slowly, this patient is ready for weaning, so let us make an attempt of weaning. And sometimes we also have the protocolized weaning. And there were a lot of controversies, debates, and we now are finding that protocolized weanings are better. Now we are also talking about computerized based weaning. Any comments on that side?
Again, like I've not seen any trial like looking at these different weaning attempts, like an individualized way weaning versus protocolized versus these new automated weaning approaches. I think there are trials comparing the protocolized versus the individualized. So again, depends on the unit where you are working, your expertise on that. And again, I'm not very used with this automated modes nowadays. We usually go with the clinical assessment and other parameters. So that depending on the way which you are used to. But obviously, if you look at the evidences, maybe we will have to more lean towards the protocolized weaning.
Protocolized weaning, true. So there are some questions related to what is the best, see, all the students need to understand there is a difference between assessing readiness to wean then weaning indices, and then extubation. So there are questions related to the weaning indices. Once we clinically decided the patient is ready for weaning, there are weaning indices which we look for. And there were some weaning indices in the question, what will be the best weaning indices, whether it is a swallow breathing index or a crop index or a CHOP index or P01. So there are some, so any lights on that?
Anup, you tell, because I feel that I don't use these indices as far as winning in my eyes is because definitely these are good topics for learning for the youngsters, and these are new things which are coming. I don't know I don't know how far they are helpful as far as practicality is concerned. If you have any experience, Anup, you tell.
I also think in the same direction, maybe like a PF ratio, the bedside assessment of the muscle power, and again, as I was mentioning, whether the patient is able to cough out, and how's the oxygenation status. Then again, whether the patient is becoming tachypneic, or even your RSBI may be like a useful
Yes.
at that point.
Yes.
Other than
Maybe RSBI is the most simplest and commonly used tool adding to our clinic.
to see whether the patient has a carbon dioxide retention or other issues. And there are again many trials comparing the difference between a CPAP trial and a TP's trial. And some of the newer papers are saying that if you go for a TP's trial, the patient, the chances of developing a cardiac failure post extubation or an underlying cardiac issues can be better assessed.
More.
Again, but we usually don't practice that. Other than that, as we were mentioning during the case, the extubation, you put the patient on CPAP and on a BiPAP, give some PEEP effect, keep the patient on negative like balance, etc. can also help.
Yeah, I think you
I
made a
tell
very
you,
important point.
I tell
Pradeep
you,
sir, you probably please answer this question. It's a very interesting topic which Dr. Anup raised.
yes.
Extubation to NIV.
Hi, just I tell you, because if you look at the good randomized trials, which says that how we should wean the patient, there are two scientists. One is Andres Esteban, and another was Laurent Brochard. The Andres Esteban was the first person. He was from Spain, and he did his study on TP's trial. And then following which, within a couple of years, Laurent Brochard, he did his trial on winning with the help of pressure support. Then both these trials were compared whether TPs is better or pressure support is better. Later on, we came to know that almost both these techniques are almost equivalent. After that, for a long time, there was no as such a trial to say that yes, something new has come. But recently, in last 5 to 7 years, after 2010, the trials with proportional assist ventilation, automated tube compensation, and this NAVA. These are the three modes which were new modes, and they were considered for winning those patients who were having difficulty. And then another mode which was people found to be very important was an adaptive support ventilation, winning through with the help of adaptive support ventilation. Out of this, people said, not people said, but if you look at the literature, you will find that adaptive support ventilation has definitely proven its utility. Because it is one of those modes which can be applied for both controlled situation as well as when the patient is breathing spontaneously. So it is a mode where you actually try to set the minute volume, and once the patient gets the amount of minute volume, whatever way it is, by increasing the respiratory rate or maintaining the pressure, whatever it is. But it has been found to be one of the best way which we can use before taking a chance for patients who are difficult to win. As far as proportional assist ventilation is concerned, it is not good for those patients where you see that those patients who are having head injury, or those who are being given high level of sedation, or those patients who fail to trigger their breathing. Because this is one breathing mode which actually only works when the patient triggers. If the patient doesn't trigger, it will not work. And then the third one is NAVA. NAVA, again, has proven to be a very good mode. And this mode was actually developed by Siemens, Mackay people, and they put that into their ventilator. And they, as you know, that the functioning of NAVA is basically an electrical activity. When the diaphragm triggers, it is sensed by the ventilator, and accordingly the ventilator gives the breathing which is needed by the patient. But again, there are many disadvantages. But till date, if you see, as far as foolproof evidences are concerned, you find loopholes with proportional assist ventilation. You may find many loopholes with NAVA, but as far as adaptive support ventilation is concerned, that has been found to be better as compared to PAV and NAVA. So these are the new developments which has taken place. But if you ask, as far as our practice is concerned, we are still following this either Laurent Brochard or Andres Esteban.
True.
Because these things are to get a NAVA in your ventilator, I don't know. But most of the hospitals,
Yes.
if you think of purchasing these modes, they are very costly.
Yeah. Not available across all the centers in a freely manner. This can be all in experimental models, and there were challenges with these also models. So, and we also were discussing about extubation to NIV. I think there are some clinical condition where that can be an option, like a patient with a COPD, where the extubation to NIV has known to decrease the weaning failure. Extubation to NIV in a patient with a cardiovascular compromise or an LV dysfunction or a diastolic failure patient, those are the areas where the failure rates will be less. And a risk post-operative cases of it, most probably the thoracoabdominal surgeries where there is a possibility of and elderly age group patients also been considered when there is a risk of failure. So we have gone through almost 120 minutes of an extensive discussion about different parts of weaning failure and their and we actually thank both Ganesh and Anjana for bringing a case and interacting with us, and we thank both Dr. Pradeep Bhattacharya and Dr. Anup for actually being with us for such a long time and discussing extensively over the case. Dr. Sasya, are you around? So Sasi, can you conclude the session?
Yes, sir. Despite busy schedule, we thank sir. Thank you for giving time and imparting your knowledge to students across the India, Pradeep sir and Anup sir. And thanks Anjana and Ganesh for bringing a complex case. Thank you everyone. We will close the session.
Thank you.
Okay.
Thank you
Thank
all.
you, sir. Thank you, Anup. Thank you, sir. It's
Anup,
a pleasure
bye.
for us. Bye-bye.